Hi and welcome to the channel. In this video, we'll be talking about acute hepatitis A. The word hepatitis means inflammation of the liver. Now, hepatitis can be caused by a numerous number of causes, including our hepatotrophic viruses such as hepatitis A, B, C, D, and E. There are other viruses, including cytomegalovirus, Epstein-Barr virus, and other such viruses. Even drugs can cause liver injury. This is called DILI or drug-induced liver injury, and toxin-mediated hepatotoxicity can also occur. This can also present as hepatitis. Now, hepatitis A virus per se is an RNA virus belonging to the family of picornavirus. It is responsible for endemics and sporadic cases and is considered hyperendemic to developing countries. Now, the main route of spread is fecal-oral route, and it is very common, especially in people living in the crowded areas. Now, the common sources for hepatitis A viruses include contaminated food, untreated groundwater, and inadequately cooked food. In developed countries, the most common cause for hepatitis A outbreaks is travel. Clinical features includes an incubation period of 30 days, and it is excreted in the feces in up to 2 weeks before the clinical illness and even until 1 week after the onset of symptoms. Usually, the feces does not contain the hepatitis A virus beyond 1 week of the clinical symptoms presentation. And we have to remember one thing very clearly, that there is no chronic or carrier stage in hepatitis A virus, unlike that we see in hepatitis B or hepatitis C or hepatitis D infections. So the mortality and liver failure is also quite rare in the patients, but it is of some significance in patients with a pre-existing hepatitis C infection. So in patients already having a hepatitis C infections, there are studies which have shown that patients have a higher incidence of mortality and even acute fulminant hepatic failure also. And as a general rule, hepatitis A is quite severe in adults compared to children. In children, most of the time it is just asymptomatic. They'll come with mild jaundice and they'll have elevation of enzymes and they'll get back to normal within a couple of weeks. So when we look at the course of illness, this graph is all we need. So as we look at the graph here, we can see that the fecal hepatitis A virus usually is not present until the 2 weeks and starts presenting at 2 weeks and will be there until around 1 to 2 weeks after the onset of symptoms also. So when we look at the onset of symptoms, we are looking at somewhere around 4 weeks, or that is 30 days. So this is the incubation period for the disease. Similarly, when we look at the IgM and IgG antibodies, which are of diagnostic significance again, so the IgM and IgG antibodies start spiking at around 4 and 8 weeks respectively, and with an initial spike of IgM which will last for until 10 to 12 weeks and then will have a declining trend, and slowly IgG titers will elevate and will come to the highest point at 20th week and will stay there for a couple of years. When we look at the clinical features, jaundice and the other symptoms, which we'll discuss about in a minute, and the elevation of the enzymes, as well as the hepatitis A virus in the serum, all happen somewhere around 30 days to 45 days. So somewhere around 4 to 6 weeks is where we see all of the symptoms of jaundice, symptoms of the constitutional symptoms, and increase in the biochemical markers, as well as the presence of hepatitis A virus in the serum can be detected at that time. So the onset is abrupt, or it may sometimes be insidious as well. So as we can see, the patient can come with a 30-day of incubation period and suddenly present with jaundice and the other features, or the patient can have a slow elevation in the total bilirubin, which comes as mild jaundice, increasing in the intensity, and then patient coming with more intense malaise and all of that. But both of them can be present. When we look at the other symptoms, patient can have malaise, myalgia, arthralgia, defervescence, which means the reduction in the body temperature, and anorexia and diarrhea. So the fall in the pulse coincides with the jaundice. So around 30 days is where we'll see the patient coming with bradycardia, or the patient will have a heart rate less than their baseline. And sometimes the patient can have fever, but fever is usually low grade and it is not high grade, and mild right upper quadrant pain can also be there. Very rarely we have to remember that patient can have right upper quadrant tenderness that is so severe that it can even mimic cholecystitis also. So jaundice usually presents for 5 to 10 days, and it slowly disappears after 5 to 10 days, and that follows a clinical improvement phase. This is the general rule. Again, as there are exceptions to the rule, there are sometimes cases which have the fulminant or the acute phase where the patient can go into the hepatic failure as well. As we have told previously, acute illness is self-limiting and it subsides over the 2 to 3 weeks after the initial onset of symptoms. But however, the clinical and complete lab recovery can be seen only after 9 to 10 weeks. So we have to remember that there is actually no point in repeating the enzymes after the clinical resolution of symptoms, because the enzymes are bound to be elevated for up to 9 weeks, including the total bilirubin also. And rarely, some extrahepatic complications can also occur, which include acute kidney injury, arthritis, vasculitis, and bone marrow suppression. And you can also see aplastic anemia as well. So, generally, the patients usually recover within 3 months to the complete normalcy. And this also means that the patient might sometimes need time to recover from their laboratory derangements also. However, in patients who are admitted or being evaluated, what we have to remember and keep in mind is that if the patients develop any symptoms of hepatic encephalopathy, even if it is mild, moderate, or severe, or if the patients have a coagulopathy, which is seen as derangement in the INR or prothrombin time, and if the severity of symptoms have crossed beyond certain limit or certain mild to moderate level, those are all flag signs and they need to be further evaluated, and such patients need to be intensively monitored. So when we look at the labs, we'll see a strikingly elevated AST and ALT. So the enzymes will be in thousands. So we'll see AST ALT of more than 1000 units per milliliter. Elevation of bilirubin is quite evident, which is typical as we see in acute hepatitis of any cause in general, and hepatitis A in particular also. So this is going to follow a phase of spike until 30th day and then will reduce over the next 2 to 3 weeks. So low to normal WBC count can also be seen, and mild proteinuria can also be seen. So mild proteinuria itself is not an alarming sign, but if the patient is going into acute kidney injury, that is where the patient needs to be intensively monitored. And as we can see, there will be marked cholestasis also, which will be evidenced by increase in the ALP and the cholestatic markers of gamma glutamyl transferases also. And IgG and IgM of hepatitis A virus also appear immediately, but they are of diagnostic importance in such patients. So any patient coming with hepatitis A virus, you are suspecting a hepatitis infection. In such patients, if the enzymes are elevated to thousands, you can suspect with the constitutional symptoms, you can suspect the patient having hepatitis A, and hepatitis A IgG and IgM can be done to completely rule out or rule in hepatitis A infections. So the treatment mainly consists of observation. Observation, and observation is the main treatment. So we don't need to give any antibiotic or antiviral as such for such patients. And it has been proven beyond doubt that steroids have no role in hepatitis A viral infections at all. So there is no point in giving steroids for any patient with hepatitis A infections, irrespective of the age. Hydration and symptomatic care are what are required the most. Another thing that we need to remember is in a patient with a fever in hepatitis A, you do not usually recommend acetaminophen or your paracetamol for the patient, because that itself can also further worsen the liver injury. Dextrose can be given in patients with hypoglycemia, so we can use 10% or 5% dextrose solutions also. In general, avoid alcohol and all the hepatotoxic drugs as well. Prevention is mainly by hand wash and sanitization. So in the household, if there is any person with suspected HAV infection, it is imperative that everyone else in the family needs to follow certain strict guidelines as to washing their hands and making sure that they are adequately sanitized after touching the patient's clothes or after even touching the patient's food and all of that. So preferably and definitely not share food with the person, but however, strict isolation is not usually recommended. And for prevention, definitive prevention, we can use hepatitis A vaccine and immunoglobulin. Whether to give hepatitis A vaccine or immunoglobulin is a question that needs to be answered based on the age and based on the immunocompetency of the individual. So, as a general rule, people who are aged more than 1 year to 40 years are usually given hepatitis A vaccination whereas people who are beyond 40 years or people who are in general immunosuppressed do not receive the hepatitis A vaccination. This is a life attenuated vaccination, so we need to be a little careful in that. And it should not be given in any patient with pre-existing liver injury, chronic liver injury going on. You should not recommend a hepatitis A vaccination for the patient. Instead, we can give immunoglobulin for the patient, which can also be given in patient as a post-exposure prophylaxis for up to 2 weeks also. So the vaccines that are available are live attenuated vaccines, so it can be given anytime before the travel also. So the two important vaccines are Havrix, which is 1440 ELISA units given as a single dose, or Vacta, which is 50 units which can be given.